channel viewers. In today's video tutorial, we have covered in detail about the recent advances in the management of gastric cancer. Highlights of this video tutorial will be AJCC classification, anatomy, TNM staging, the lymph node station according to the Japanese classification, the extent of lymph node dissection as per the Japanese latest classification, lab versus open distal gastrectomy in early and advanced gastric cancer. Then we will discuss about perioperative chemotherapy and reconstruction option and Korean practice guidelines that we have covered in the last part of the video tutorial. We will discuss about distal gastrectomy, that which approach is better, lab or open. Can we reproduce the result of distal gastrectomy with the help of laparoscopic distal gastrectomy? The major milestone in the use of laparoscopic surgery in the treatment of gastric cancer was the publication of result of a South Korean study, that is KLASS class 01. This non-inferiority study compared laparoscopy with open surgery for the treatment of early distal tumors. The laparoscopic method presented lower occurrence of surgical complications related to the surgical wound without inferiority in relation to the disease-free survival in 3 years. So we will discuss this Korean study KLASS class 01 in detail to understand the pros and cons of laparoscopic distal gastrectomy. So this trial by Kim H.H. et al. Was published in JAMA Oncology in 2019 from the Korean centers. This is effect of laparoscopic distal gastrectomy versus open distal gastrectomy on long-run survival among patients with stage 1 gastric cancer. So in this trial, only stage 1 patients were taken. The trial ran from Jan 2006 to August 2010 and it was published in 2019. So in this trial, there were total 673 patients in laparoscopic group and 686 patients in the open distal gastrectomy group. They have compared the gastric cancer related deaths and other malignant tumor related deaths, recurrence, locoregional hematogenous, peritoneal, distal lymphadenopathies and mixed, and they found that there was no statistically significant difference in the two groups. They have compared the overall survival and cancer specific survival, and they found that there was not any statistically significant difference between the two groups in the Kaplan-Meier survival graphs. So in this trial of total 1,416 patients, the 5-year overall survival was 94.2 in lab and 93.3 in the open group. The 5-year cancer specific survival rates also similar between the two groups, that is 97.1 in lab and 97.2 in the open gastrectomy group. So they concluded that laparoscopic distal gastrectomy is an oncologically safe alternative to open surgery for the stage 1 gastric cancer. I have given the link this landmark study in this tutorial, and I urge the viewers to go through this important landmark paper to have in-depth knowledge of this paper, as this paper defined the priority that laparoscopic distal gastrectomy is an option in patient of distal gastric cancer in stage 1 tumors. This is another important study from Japan Clinical Oncology Group study, that is JCOG 0912 study, and it is often quoted in the textbooks and other papers. In this study, they have studied the short-term surgical outcomes from phase 3 study of laparoscopic assisted versus open distal gastrectomy with nodal dissection for clinical stage 1A and 1B gastric cancer. In this study, the adenocarcinoma middle and lower third of stomach patients were included, and clinically stage 1 tumors from March 10 to November 13 were enrolled. Total 921 patients in laparoscopic group 462 and open group 459. Clinical stage 1A, that is T1N0, and 1B T1N2 or T2N0 were there, and they have studied non-inferiority of lab to open in terms of recurrence-free survival. They did D1, D1 plus and D2 lumpectomy stage 1A, and all stage 1B tumor, that is T1N1 or T2N0, they did D2 gastrectomy. In this study, the operative time was more in the lab group and the blood loss was more in the open group. Rest of the parameters were similar So in this study, that is JCOG 0912 by Katai et al., which is published in Gastric Cancer in 2017, they concluded that laparoscopic distal gastrectomy was as safe as open in terms of adverse outcomes and short-term clinical outcomes. And they recommended that laparoscopic assisted distal gastrectomy may be an alternative procedure in clinical stage 1A and 1B gastric cancer if the non-inferiority of laparoscopic distal gastrectomy in terms of recurrence-free survival is confirmed. This is another landmark paper by Cohen Group and which is published in Annals of Surgery in 2019 by Lee et al. In this, they have compared the short-term outcomes of multi-center randomized controlled trial comparing laparoscopic distal gastrectomy with D2 lymphadenectomy to open distal gastrectomy for locally advanced gastric cancer. So, viewers, the first trial, that was class 01 RCT, was for stage 1 gastric tumors only, and in which they proved the equivalence or the non-inferiority of the lab distal gastrectomy. And in this trial, they have compared the non-inferiority of lab distal gastrectomy in locally advanced gastric cancer, that is T2 and 4A and N0N1 status. So in this study, total 1050 patients were enrolled in lab group 526 and open group 524. Did standard distal gastrectomy with the D2 lymphadenectomy in all the patients, and station 1, 3, SB and D, 5, 6, 7, 8, 9, 11P and 12A were cleared, including total lymphadenectomy in both the lab or open group. So in this study, the operative time was more in the laparoscopy group. In this study, the operative time was more in the lab group and blood loss was more in the open group, which is expected outcome, and both were statistically significant. Rest of the criteria, extent of dissection, lymph node dissection, anastomosis, amantectomy, and R0 R1 status were similar in the two groups. The overall morbidity was less in the lab group, and local complication like bone fluid collection and abdominal bleeding were less in the lab group, which was statistically significant. Rest of the parameter like systemic complications and clavin-endo complication, they were similar, and there was no statistically significant difference between the two groups, that is lab and open, including the readmission and 90-day mortality. So the authors of class 02 randomized controlled trial and the Cohen group concluded from their study, this RCT, that lab distal gastrectomy with D2 lymphadenectomy for locally advanced gastric cancer shows benefit in terms of lower complication rate, faster recovery and less pain compared with open surgery. They are yet to report the long-term outcome of these two groups in terms of recurrence-free survival and cancer-specific survival.